All right, okay, so I've got probably more than 2 cases, but I'll try and just focus on 2 cases. The first case is a 36-year-old lady. These are all new cases of mine in the last few weeks, by the way. 36-year-old lady who presents with a 9-month history of fresh rectal bleeding to a general practitioner who thinks it's hemorrhoids and does nothing. Eventually she sees another general practitioner who does a PR and finds a mass and sends her to our outpatients. She has a history of vaginal hysterectomy only recently for vaginal prolapse, previous pregnancies, 2 children. I did the endoscopy myself on digital rectal examination. It was very uncomfortable. I could feel a palpable anal lesion, a rectal lesion, which obviously concerning for cancer. I went ahead and did some biopsies. I couldn't get past the flexible rectal sigmoid junction because it was just an uncomfortable test. The histology is reported as being an invasive adenocarcinoma, moderately differentiated adenocarcinoma. She then goes on and has staging MRI and CT scan. The MRI, I haven't got multiple films, so you have to just believe me. The MRI, our radiologists could not identify the origin of the primary tumor convincingly. There were definitely no perirectal lymph nodes or pelvic cycle lymph nodes. CT doesn't show any disseminated disease in her liver. What would you do next? Would you perhaps do a further evaluation in EUA, partly because it's just uncomfortable to do this in the endoscopy room? Would you go straight for an APR? Or would you consider neoadjuvant chemotherapy or 3 or 4 options, or do something else?
Please vote.
Where exactly was the tumor?
The tumor is in the lower rectum. It's a lower rectal tumor, so it's actually just
Posteriorly.
right posterior, yes.
What level from the heart?
It's right on top of the anal canal. I'll tell you more as I go on, but clinically, it's just sitting on top of the anal canal.
Okay, vote please.
The MRI there was no visualized tumor on the MRI. The radiologist could not see it.
The size of the tumor.
They couldn't see it, but I'll tell you more clinically.
And the finger. Digital examination.
Well,
will tell you.
Just tell me what you'd like to do here. Okay? Will we score that?
Okay.
Let's say that's you.
That's our results.
Okay, so I because as you say, Professor Hagenberger, I couldn't quite assess this tumor properly. I decided to do an examination anesthesia because it was just too uncomfortable in the outpatients, and I decided to do an indirect ultrasound myself, 3D ultrasound, to try and see if I can better stage this lesion. Now I don't know if you can see this clearly, but you know, what you've got here is a very low rectal cancer with the tumor effectively spreading along the mucosal surface of the anal canal to the dentate line. There was no suspicion that it was actually invading into the sphincters, but just kind of mucosally spreading. But the origin is the rectal cancer. I did the 3D ultrasound myself. The beautiful thing about 3D ultrasound, you can take multiple images, like an MRI, CT scan. You can view it with several radiologists. And clearly on radiology, I have the impression that it was a T1 tumor. I struggled a little bit. At some point, I thought it was a T2. So I was sort of somewhere between T1 and T2. So in summary, we have a T1 stroke T2 tumor, low rectal cancer, mucosally going into the anal canal, and a 36-year-old lady who we can't stage adequately on MRI scan. So where would you take this now?
Please vote. What to do next?
Okay. Okay, so we have
Option 4. Neoadjuvant chemoradiotherapy to shrink the tumor.
and hopefully downstage the tumor. Okay.
Wait.
Any comments? Glenn Jones.
Comments? Yes.
Okay, so this is a small, superficial T1, T2 tumor.
I agree.
Okay, and you're going to give chemoradiotherapy to the whole mesorectum for a lady who's had a hysterectomy and we'll have a nice lot of small bowels stuck down there. That's really nice. You're going to make her quality of life very nice in the future.
Robert, that's 56% of the audience, and not me, by the way.
So,
I do agree.
I would ask one of my colleagues that does papillon, whether
Yes.
papillon would be suitable for this patient.
Okay, so endoluminal radiotherapy.
I missed some information about the gyno operation. What has happened? What did they do?
Yeah.
Could they find it on the MRI as well? Because that will probably compromise your local situation with the surgery.
They did a transvaginal hysterectomy because she had a prolapse.
Yeah, but the pelvic floor repair, what was happening with
I
that?
don't know the details of that
I
prolapse.
think for me that should be reported.
Okay.
Any other
comments?
opinion? It was suggested that the patient, I mean, by the audience, that the patient should have the neoadjuvant treatment. Any other disagreement apart from Rob's or anyone else? Gina? What?
So, if the radiologist had been taking part in the PRESERVE trial,
Yes.
we would not expect that kind of report. Essentially, we would not expect anyone to say, "I can't see the tumour,"
Okay.
because that's not
They
how
have
we
to
train.
see something.
Well, what we would do is we give them a whole series of early rectal cancers to stage, practice on, and then we test them, and they come into the study with a kappa of 0.8, 0.9,
Okay.
so that they don't miss important bits of disease. So my feeling from just looking at that tiny snapshot image is that the radiologist could have given you more information. For example, that the muscularis was completely intact. They could tell you that much.
Yeah.
They could also tell you that they could see the submucosa, and it was a normal morphology of the submucosa. And if they couldn't see that, then they would need to repeat the scan with a proper protocol, because you should be able to see those things.
Okay.
So, having said that, that means that if, two scenarios, either they'll say they can see the submucosa fully, in which case this is a very superficial tumour, and you would look at the scans together to figure out if it's feasible to do a local excision in the submucosal plane, bearing in mind you're right down by the sphincter.
Yep.
And in that way, going deep to the submucosa, just at the interface with the muscularis propria, you could even get more than 1 millimetre clearance at the base of the tumour and actually have sorted out the problem and saved her sphincter.
Yes.
So that, we've done that, and that's what we're going to be testing in the PRESERVE trial.
Right. I mean, with this lady.
Deep invading the submucosa, you wouldn't advise for neoadjuvant before.
No.
Because we discussed that in the morning practically, but...
We did. So the point is that you don't know until you see.
Okay.
So if the radiologist is over,
you mean locally
and look what you've got, and base your decisions on that, because actually you may have got away with it, and then you would have avoided that whole scenario that's going to cause...
Who agrees or disagrees with what Gina said?
I just think you're taking a huge risk, because if you do a local excision, even if it's R0, if the patient gets a recurrence, which is not that common, then you're in a real problem, because they will not respond to the same degree as the primary tumor, and then you definitely end up with an APR.
So Gina said there might be a tumor with good features, not high risk features, and maybe that is enough for the patient.
It may be, but if MRI is wrong, which it is now and then, Gina, you have to admit that, then you're in trouble, because you
No,
have...
you're not in trouble. Can I explain why you're not in trouble? Can I please explain why you're not in trouble? So, what I just said
was that if you're doing it, and as I said, the plane of dissection, if the submucosa is preserved, is not the muscularis propria, it's not the external sphincter, it is just the plane between the submucosa and the muscularis. So you have lost precisely nothing from doing this, and everything to gain from doing it. And we've got lots of cases of this when this kind of precision is done. So you're conflating two problems. One is that the radiologists are capable of doing it, and I would say to you that once they're trained and know what to look for, they will be capable of doing it. And the second issue is you're using old historic data about removal of destruction of the planes and so-called free-form TAM.
of this sort down there.
Yeah, so we know this. So actually, if you don't go far out, if you just stay in the correct plane and you preserve a millimetre at the invasive border of the tumour,
So,
you will get a
to make
clear,
long story short,
clear margins.
excision
With-
with a minor histology.
Yes.
And,
Okay.
and
The problem with
this
this,
will go fast. You disagree or
We will
not?
do the
Yes, I disagree with the local excision. So
Please.
this lady has probably continence problems already. And if you excise the tumor at that site, so you will certainly perfectly deteriorate any residual function of the sphincter.
let me explain. I mean, first of all,
What did you do,
this lady
John?
hasn't got any continence problems, but if you look at the level of the tumor coming up to the dentate line, there is absolutely no way I can do a sphincter preserving excision of this and preserving her anal sphincters. I can't do that.
Is the dentate line involved?
Yes, the tumor comes up the dentate line. This is not a non-discussion. Okay,
Okay,
so
what did you do?
So I go back to Robert. That yes, what are the risk factors of this lady actually having local recurrent disease? And actually, there are quite few, nothing in fact. So the risk factors from this Japanese study are really circumferential margin, the size of the tumor, hair size of the tumor is less than 4 centimeters, circumferential margin negative, which she is, and also histology. So she actually has all factors which should, in real world, allow us to go straight for surgery, which in this case will be an APR in a 36-year-old lady. That is the standard of treatment. I may have answered the question, but I'd like to answer this question back to you. Now that you know the risk factors of local recurrence is extremely low, does it change your mind what you do for her?
I think Rob's...
Let's have a vote on that, by the way.
Let's vote first and then comment. Okay.
Keep voting anyway. Sorry, you going to say something?
I think in many ways Rob's suggestions sound brilliant to me. Try, why not? I mean, isn't she an ideal candidate for contact radiotherapy?
Okay, that is an option.
Small, localized tumor.
Okay.
And if this doesn't work, otherwise the second alternative in my opinion is straight for an APR.
Okay, I agree with you. So Papillon or straight for APR.
So,
Now, Robert, I'm just going to throw this back at you again.
David,
Okay, in your talk, you said early T1T tumors respond well to chemoradiotherapy.
They do.
Yes, and this is from the TREC studies, which showed that 30% of these patients will actually respond to get a complete response. So does that swing the argument again that we should give this lady chemoradiotherapy with the hope that she might cure herself?
Well, I don't like the fact that she's had a hysterectomy because I would like to see where the small bowel is. I mean, it's often stuck down there.
Okay.
And also, you've had some pelvic floor surgery as well.
Okay.
So, you know, I don't do papillon, but this would seem to me an ideal patient with a superficial small tumour. It gets a bit difficult as you go down, the lower down you go.
Okay.
But you can give 120 Gray to that.
Okay, I agree with you. So anyway, at the present moment, we've not operated on her, I'll be honest with you. We in our unit, we've recommended going for APR, although the Papillon is a good option. She's reluctant to go down the APR route and would like to explore options in terms of sphincter preservation. And in our MDT, we've decided that we'll offer chemoradiotherapy on the basis that she understands that most she has 30% chance of cure, but the downside is that she has a 70% chance that she may not benefit from this, and she'll have the long-term side effects of chemoradiotherapy and still need surgery. So there you go. Any? Yep.
one more case. We
One more
have
case.
time. Yes, please.
Robert, go ahead.
She's 36.
Yes.
Right. She's probably sexually active. I think
Yes.
papillon, if you've got a posterior tumour, your papillon, if it works, will preserve sexual function
Right.
as well as it could possibly be preserved.
I think it's a good option, and I'll go back to our MDT and raise that as an option. Thanks, Robert. Okay, well, I'll try and present a short... Yeah, I'll present a short case now. 79-year-old patient who has presents with rectal bleeding, history of COPD, angina. He has an endoscopy. There's a mid-rectal cancer. It's been biopsied, it's proven to be an adenocarcinoma. He has a staging MRI scan which shows a T3B M0. He has a CT scan which they're suspicious about a caudate lobe metastatic disease, about 6 millimeters. At this point in time, he presents to me only 2 or 3 weeks ago. I see him in the outpatients, and interestingly enough, his main complaint is pain in his anus. And the first thing that strikes to me is that mid-rectal cancer does not give you anal pain. So I examine the patient. These are not his actual original patient images that I took them from Google, but just to give you an idea of what I was looking at. And he has an anal lesion, which everyone seems to have missed before he came to see me. So he has his anal lesion. My dilemma here is that, is this a mucosal deposit from his rectal cancer, or is it a separate lesion? I then do an EUA and biopsy of these lesions, and these are histologically assessed, and it comes as being a squamous cell carcinoma. So he has 2 synchronous diseases, mid-rectal cancer and anal squamous cell carcinoma, which is stage 1 disease. The liver lesion is now evaluated further with an MRI, which says that it's not a metastatic disease to the liver. So what would you do at this stage? You are expect, Robert.
This is not a lymph node, possibly an endoluminal lymph node that's grown through in the rectum.
No, this is 2 separate histological diseases.
So you've got
One, rectal adenocarcinoma and an anal squamous cell carcinoma. Synchronous in the patient. This is the first time I've seen it, I promise you.
I think I'm going to the library.
Okay. any options what we should do here, by the way? You have 4 options. Okay, neoadjuvant chemotherapy, straight for APR. Well, in this situation...
To cure what?
Sorry?
To cure what? The rectal cancer, the adenocarcinoma, or the squamous cell carcinoma?
Which one?
Of the anus. Which of the 2?
Okay, well, whatever treatment you choose has to cure both. I mean, there's no point in doing one or the other. So if you're going to go for chemoradiotherapy, you want to do chemotherapy, which hopefully...
Different drugs, though. Different drugs, though.
If you want to go for an APR, hopefully an APR will treat both conditions.
But what is the staging? The stages of it?
Okay, so the radiological stage of rectal cancer is T3B N0. The anal cancer is stage 1.
What about the EMVI?
It's EMVI negative. I'm just focusing on what's possible.
You have the command in middle of this case.
No. Gina, I apologize. I'm just focusing on the facts, that's all.
T1 anal cancer and T3A you said, or B? B. EMVI
negative. No,
negative. Nodes negative. We don't bother about nodes. We said.
Just can I see the images?
Did you
I haven't got.
give the patient
I'll send it to my Google Drive.
targeted to which of the 2 cancers? Because you have to use different drugs.
Well, if you've decided you're going to give chemoradiotherapy, okay, then you would probably give capecitabine and oxaliplatin, and then you would cover both.
Cover both. Don't bother about metamycin.
Well, you can give mitomycin if you like, but it's not a drug that we use terribly much in adenocarcinomas.
But in adenocarcinomas you give capecitabine and radiation only.
You should do that.
It's a way to change.
But the radiotherapy fields are completely different, and I don't know.
Okay, you decide anyway.
I'd struggle with that.
Okay. Anyway, because we have the suspicion of a liver lesion, we decided to do a PET anyway during the MDT. The PET was only done on Monday, so you look at these images, they've not been formally reported, but my impression is that there's no evidence of metastatic disease. So it goes back to that initial question, what are we going to do? Now, we've discussed around MDT. There are various different protocols that look at which can offer neoadjuvant chemoradiotherapy, and oncologists are keen to go down the neoadjuvant chemoradiotherapy first, offer metamycin and capecitabine, and then restaging and then doing something surgical. Now, just to keep things going on, let's just assume that he has a complete response of his anal cancer. which we expect from a stage 1
That's the
disease.
good question.
What do we do with this guy? From Robert's talk, we have to observe him for at least 6 months before we can say he's cured, but he's still got a rectal cancer. So, what am I going to do?
Don't you think you have to take into account the response of the adenocarcinoma also to treatment?
I'm making this assumption that the rectal tumor is still there.
Any idea?
But it's been irradiated, it's part of the field. It's been part of the field.
Any idea, anyone?
I'm a very simple surgeon. If according to the Danish guidelines, it didn't need neoadjuvant therapy, the rectal cancer, and you have a very small anal cancer, you know, I'll vote simply to do, and I'm sorry, I might be old-fashioned, to go straight for surgery for an API and solve both problems at the same time. A simple surgeon.
Yeah, but the problem is that they don't do so well, the anal cancers. You should be able to cure the anal cancer with chemoradiotherapy, which you don't usually do with an APR.
I agree with you, Robert.
For a very early cancer.
I agree with you, but from a surgical point of view,
so who would go for an APR?
Oh yeah, thank you.
Who would go, as Rob says?
I'm not sure I said anything. What did he say?
Surgery, APR?
APR.
He's 79 years old. Come on. APR.
He's 79, he's got COPD. Anna told us these people do well, do bad, brother.
Radiotherapy, and then, I mean, how is the anal function of Lars after radiochemotherapy to the pelvis?
Don't go back to this.
No,
discuss it for ages.
Come on, and then high dose radiotherapy to the anus. I mean, what is this function? I think I can compete with Søren and Werner. Go for an APR directly, cure both diseases, one operation, and everything is finished.
And listen. You have a failure rate, didn't you say, Rob, about 20% for anal cancer? For chemoradiation. Long term. Okay, but you have at least a failure rate of 20% for a rectal resection with a diversion that's never closed. It's about 20%, and then you have all the other things on top of it. Why not make it simple?
Anyhow, let's ask the.
And I agree with you.
The
The more I
responsible
think,
surgeon.
I agree with you, because to give him chemoradiotherapy, then to do an anterior section, a 79-year-old man, you don't know what's going to happen to you in anastomosis.
What would you do?
We've not. I thought he's just seen this guy in the last 2
What
weeks.
is your
My
opinion?
plan is most probably an APR.
For an APR.
Correct.
Okay.
Thank you.
Thanks very much.
Thank you.